Hello, my name is Jenna Wallander-Gemko, and I'm a research coordinator with Alliance Chicago, one of two organizations leading the Chicago Collaborative for Maternal Health, which I'll be speaking about for the National Maternal Health Innovation Symposium. Alliance Chicago's mission is to improve personal, community, and public health through innovative collaboration. Alliance Chicago is a health center-controlled network, and our efforts are focused in three core areas: healthcare collaboration, health information technology, and health research and education. Alliance Chicago maintains a diverse portfolio of research initiatives using real-world data from across our network of community health centers to provide insights, produce meaningful outcomes, and explore important health-related questions for underserved populations. We promote capacity building and training to broaden and improve the skills of our network in generating and participating in research that addresses health disparities. While maternal mortality and morbidity have been rising in the United States over the last several years, we've seen both mainstream media and public attention shift more significantly to this public health issue, along with attention to structural racism's impact on health inequity and access. This, of course, has been exacerbated and highlighted by the COVID-19 pandemic. But none of this is new to providers, public health practitioners, and especially people with lived experience. At the same time, we see disparities in access to primary care across the lifespan. And how does that impact wellness for birthing people before, during, and after pregnancy? Alliance Chicago is uniquely positioned to engage with this question because of our relationships with health centers and how we model our work. The data coming out of the Illinois Department of Public Health and Chicago Department of Public Health confirms and aligns with what we are seeing across the country. IDPH found that in its measurement period of 2008 to 2016, 73 birthing people on average died each year within 1 year postpartum. Non-Hispanic Black mothers were 6 times as likely to die as non-Hispanic white mothers of a pregnancy-related condition. And 72% of pregnancy-related deaths were deemed preventable by the maternal mortality review committees which authored the report. CDPH found in its measurement period of 2016 to 2017, the severe maternal morbidity rate overall in Chicago was 74.1 per 10,000 deliveries. This was more than 2.5 times higher for non-Hispanic Black birthing people than their white counterparts. Those with high economic hardship, defined via the Economic Hardship Index, had the highest severe maternal morbidity rates and the highest pregnancy-associated mortality ratio. And we want to note the nuances in how these data are defined. Pregnancy-related refers to an event that occurs as a result of a pregnancy complication. Pregnancy-associated refers to an event that happens within 1 year of the pregnancy, regardless of cause. Additionally, we know that we are not coming to this work in a vacuum. Several initiatives across the state and city are working to address maternal health through various approaches and models. Again, COVID-19 has emphasized so many barriers to access, especially for Black mothers and mothers of color, most notably through the closings of birthing hospitals on the south and west sides of Chicago. This is why we are excited to be funded through the Merck for Mothers Safer Childbirth Cities initiative in partnership with EverThrive Illinois. EverThrive Illinois works to improve the health of women, children, and families over the lifespan, and one of their primary areas of focus is maternal and infant mortality. Launched in October 2018 by Merck for Mothers, Safer Childbirth Cities fosters local solutions that help cities become safer and more equitable places to give birth. Chicago is one of 9 U.S. cities to be funded in this initial cohort, and we were funded in the fall of 2019, and our project will last through the fall of 2022. The Chicago Collaborative for Maternal Health seeks to combat the maternal mortality and morbidity crisis in Chicago by building awareness in communities and government, fostering collaboration among health and social service providers, and driving quality of care in ambulatory care settings. The CCMH envisions a Chicago where all people and all communities thrive because healthcare providers, policymakers, community organizations, individuals, and families partner with intention to improve maternal health. The CCMH has 3 aims, and the first one is led by us here at Alliance Chicago. to develop a quality improvement collaborative for ambulatory care providers focused on best practices in maternal health for systems and culture change. EverThrive leads AIM 2 and AIM 3. AIM 2 is to implement a complementary community engagement effort that informs families and community social service providers about maternal morbidity and mortality prevention, and to determine and advocate for policy recommendations based on the learnings for AIMs 1 and 2. Today we'll be focusing on AIM 1, the QI Collaborative, but I want to emphasize that the overarching goal of our work is that these aims are to complement and inform each other to result in systemic and sustainable change. As you can see by how we are structured, the most important mechanism for that integration is the incorporation of people with lived experience to be key advisors, so we can ensure our work is representative of the communities where we work and the patients we serve. Diving in a bit deeper to the QI subcommittee, you can see that we have quality improvement teams on the ground who will actually be implementing the first quality improvement initiative over the next year. And this has been an intentional process over the last several months, resulting in a few different levels of partner engagement. The larger QI subcommittee is made up of all of our engaged health center partners to learn with each other. The QI development work group is a work group, a smaller subset of this group that has helped us over the last several months to refine our first quality improvement initiative and the measures we will use to evaluate. Finally, the QI implementation sites will be, as mentioned before, on the ground executing the initiative and could be a wide variety of staff depending on the workflow of each health partner. We expect this to be a cyclical process and to be constantly learning and even tweaking as we go. We also expect to take lessons learned from this first implementation cycle forward into our second initiative and even beyond the course of the CCMH project as it's currently funded. As we engage stakeholders, we developed a roadmap with the assistance of the Illinois Perinatal Quality Collaborative, and we've been grateful to lean on their expertise during this process. Each of the deliverables on this slide have been important to informing our work, but most important for us was ensuring that the initiative would be chosen by our partners. To accomplish this, we disseminated a survey to our subcommittee of engaged health center partners before our first meeting. We also wanted to meet our partners where they were and are at, and to that end asked questions about their QI experience in general, as well as any experience they had with QI within maternal health. We found that we had a fairly even split across the group in terms of implementing maternal health QI. And across the board, capacity, budget, and time were the primary barriers noted. Similarly, across the board, respondents noted provider input, evidence-based practice, and data sharing as important facilitators to QI work. As you can see, several topics were proposed to the stakeholders across the perinatal period, and they were also given an option to suggest additional topics that were not originally reflected. Overwhelmingly, the postpartum period was prioritized, the highest priority being a linkage to primary care provider following a medically complex pregnancy. The American College of Obstetricians and Gynecologists, or ACOG, recommends that postpartum care providers include the transition to well woman care as part of the postpartum care plan, and that additional referrals should be made as appropriate. ACOG additionally notes that the transition needs to be documented in the medical record and communicated with the patient and all members of the care team. Additionally, evidence supports the primary care provision to high-risk prenatal patients, such as patients with gestational diabetes and postpartum depression, to reduce disparities in treatment and improve health promotion. And I should note that while we conducted this survey pre-pandemic, we did survey partners again when we were able to reconvene this summer, and this was still of most interest. As we've progressed forward and are currently in process with the QI development work group, we have moved into thinking about what intervention could both accomplish the highest priority of our stakeholders and also potentially achieve additional positive outcomes in the postpartum period that were of interest. Additionally, given our partners' concerns over time and capacity, our goal was to propose an intervention that could be tailored in whatever way would be useful and aligned with the unique workflows of each partner, while also standardizing the evaluation measures enough that we will be able to see what is working and what is not. So if our goal is to ensure prioritized health services received in the postpartum period, specifically linkage to the primary care provision, we started to think about how we could work backwards from that outcome. And our idea in collaboration with the QI Development Work Group was to develop a tracking list or registry and a process to follow high-risk patients, taking a population health approach. This accomplishes a couple things. First, it's giving health centers the ability to determine who, in terms of who they define as high risk and who gets criteria for entry onto their registry. And also it allows health centers to determine how, in terms of the technology, which staff are in charge of oversight of the list, and how the list is communicated to all relevant staff. Again, this allows us to standardize our measures across all of the health centers, no matter what route they choose to go. For example, is a registry or process in place to identify high-risk patients? Is a process in place to coordinate care for high-risk patients? How many staff are trained and by type? And how many patients are linked to their primary care provider at their delivery discharge within 3 months? And how many patients are receiving additional care for the reasons why they were on the list in the first place? For example, gestational diabetes. Next steps for us are grounded in the implementation and evaluation of our first initiative, and ensuring our implementation partners feel ready and supported going into and throughout implementation. We'll be holding technical assistance calls and convening virtually so partners can engage with each other with what they are learning and how we can improve. This will eventually lead to us working with partners to see if they can sustainably continue the work and supporting them in how they choose to move forward once the implementation period comes to a close. While we still have a long road ahead of us, we have already been so grateful for the time and thought our partners have put into the work so far. We'd encourage you to ask these questions on your own quality improvement journey. Thank you for your time, and please reach out with any questions.